Our next talk is going to be an update on current research on caregivers, which is a really important topic. And we have two fantastic experts to help us give this talk. One is Michelle Keller, who's an assistant professor in gerontology at USC. And she is a health services researcher who also is trained in epidemiology, qualitative research methods, and her work really focuses now on reducing low-value care. And for those of you who don't know what that is, I'm sure she can talk to you about it over the break. She also has research on facilitating patient-clinician communication, increasing dementia identification in minority older adults, and improving medical management in diverse populations. She has a wonderful bio, and I'm going to just mention a couple of other things. She has worked as a journalist for publications like the LA Times and the Chicago Tribune. And she got her PhD and MPH in health policy and management from UCLA and a bachelor's in human biology from Stanford University. So it's staying with the theme of highly accomplished women scientists with phenomenal training who are making our center work better and even better. We're very happy to have you with us today, Dr. Keller. And her colleague, and I don't know if you're going to co-present or go back to back here, is Dr. Francesca Falzarano, who is an assistant professor in gerontology at USC. She is a developmental psychologist whose research is focused at the intersection of technology and dementia care, with a particular emphasis on enhancing the mental health and well-being of family caregivers. Francesca got her bachelor's of science in psychology from Manhattan College, a master's degree and PhD in applied developmental psychology from Fordham University. And she also was a postdoctoral fellow in the Division of Geriatrics and Palliative Medicine at Cornell Medical School. So thank you both.
Wonderful. Can everybody hear me?
Yes.
Yes. Okay. Fantastic. Wonderful. Thank you so much for the very kind introduction, Carol. We really appreciate it, and it's such a privilege to come talk to this wonderful group today. Today, I'm going to be talking about one of the topics that's near and dear to my heart, which is really about how do we help families? And we say caregivers, but oftentimes it's and I think that's it's really someone who we love, right? Someone who is a loved one. How do we help them with this very complex task of optimizing their medications? And I'm going to be talking about kind of some of the challenges and some of the solutions that we've, that research has kind of found in trying to really help older adults and their families. And I should say, this isn't actually unique to older adults. I think this can be really, a lot of this research is in that population, but certainly, research that can be applicable to all sorts of populations. Wonderful. A couple of disclosures. I am a scientific advisor for an AI company because it is, of course, AI times. And of course, I've received some research from the National Institutes of Health and NIA. As Carol mentioned, I am a health services researcher. I'm also part of the USD Prescribing Network, which is a network of researchers and a lot of stakeholders who are really interested in how do we try to make sure that our families are taking drugs that are, really optimized for them, which in many cases means actually stopping or reducing the dose of some of the medications that they may be taking in order to actually improve their health. And this is a large part of my research. Okay, fantastic. So, just to kind of, and I think this is a group that knows these harms quite well, but to kind of make sure that we're all on the same page. We know that as we get older, we see a lot of changes in our body that makes it more difficult for us to withstand some of the harms of medications, right? So, for example, our kidney function starts to decline over our lifespan, which means that we have a harder time kind of getting rid of medications. We also have changes in terms of, for example, how much blood gets into our liver, or even just the size of our liver, which also makes it more difficult for us to break down medications, meaning that some of these medications stay in our bodies for longer periods of time. What this can result in is, we see this with family members. We might have increases in falls or fractures. We're on the topic of cognitive impairment. We know there are some medications that are highly associated with actually increased risk of dementia and just cognitive impairment overall. Delirium, whether somebody is hospitalized or not, they may are at higher risk of delirium if they are taking many medications. Oftentimes, some medications can lead somebody to have a high risk of hospitalization. They may start bleeding in their stomach. They may fall. They may have a traumatic brain injury, to kind of talk about some of the things we've mentioned earlier, and also associated with increased mortality. So how serious is this issue of polypharmacy? There's all sorts of studies that have tried to capture this, but one kind of statistic is that about 42% of older adults are taking 5 or more medications, and 20% are taking 10 or more medications. And just in terms of the actual reductions that we could see, if we were able to really optimize medications for our population, we would save over $62 billion in hospitalizations over the next 10 years. So why focus on caregivers? Medication management, we've been, and I think the panel this morning really framed it very well. It's medication management is an incredibly common task reported by informal caregivers that perform medical tasks. So nearly 80% of caregivers end up managing medications in some way, whether that's preparing pill boxes, administering medications. In recent years, there's been a real trend of trying to reduce hospitalizations or reduce the amount of time that somebody spends in the hospital, which is wonderful, right? We don't want people in the hospital. What that means is that people might be discharged sooner, putting some of that burden on caregivers, right? The whole hospital at home movement means that the caregiver becomes the nurse and is administering some of those medications. More than half of caregivers actually administer 5 different prescription medications a day, and 20% administer 10 or more. And we've all gone through that process where you're trying to make sense of the prescription instructions, and things conflict, and some with food and some without, and some have to be taken at very particular times a day. So these are very complex tasks. As I mentioned, it's difficult and time consuming, and people are kind of thrown into this world without a lot of training, right? All of a sudden, somebody might be hospitalized and been discharged with a very different kind of medication regimen, and the caregiver has to figure this out, and they may not necessarily know what side effects to look out for. Is this dizziness normal? Is it to be expected? Is it something that I should be worried about, right? There's not a lot of information given to folks. And we also know that transitions of care. So when somebody, for example, ends up hospitalized and is, transitioning to home or to a different level of care, that's a very stressful event. And so even though, our very wonderful healthcare providers might be doing an excellent job of explaining instructions, the amount of information that's actually captured during this really stressful event may not be 100%, right? It's just an overwhelming time. And so medication management as a result has been identified as a really major challenge for caregivers. I think importantly too, there's often not a recognition, within, and particularly within our electronic health records, that there may be multiple caregivers caring for one person, right? So that one person goes, picks up the person in the hospital, right? But those medication regimen changes may not be well kind of discussed amongst, a group of family or friends who are caring for that particular person. Even with our primary care providers, there's some change of that, of course, with electronic health records becoming somewhat, communicating with each other a little bit better. But oftentimes that doesn't happen. And so, it can be a game of telephone, right? Like one person hears one thing and then that gets transferred over. So what sort of medication management activities do caregivers do? We talked about some of the kind of very obvious ones, right? Actually physically handling medications, preparing the pill boxes, helping with medication administration. But then there's really the much more complex task, as I mentioned earlier, in terms of things like organizing and tracking medications, gathering information for the next healthcare encounter to try to bring up any adverse effects or changes in that person's health, and making treatment decisions. Many of these medications are dispersed as needed, right? And so you have to, as a caregiver, working with the person that you're caring for, actually determine what is needed at that time. So there's a lot of kind of really important cognitive complexity to this work. And there's also, I think, and I think this was brought up in our first panel really well, there's also a really important aspect of language barriers. You know, in terms of, you know, we already know that this is a complex, you know, complex information that's passed on from, you know, from healthcare providers to caregivers, and adding on top of this, layering on top of this, some language barrier issues is really challenging. We did a qualitative study with, we wanted to understand how is medication management in the hospital, how does that kind of, what are the uses of interpreters and translated materials amongst healthcare providers? So we interviewed pharmacists, nurses, and physicians to try to understand, you know, within a healthcare setting, what sorts of, you know, tools that they use, that they regularly use an interpreter, and that they regularly use translated materials. And one of the areas in which we found kind of some real gaps was in the translated materials that were provided to patients and their families at discharge. They were often not necessarily you know, any changes in medication were not necessarily translated or available in the patient's language of choice. Or, you know, and again, this is an added complexity, right? The electronic health record could show that the person who is receiving care may have one language, but the caregiver actually may have a different language that might be a language preference. So there's just some limitations in terms of how our electronic health records are being set up that may not really facilitate that information dissemination. Oh. Here, oh, one more. We also did a study where we interviewed Latino caregivers of Latino older adults with dementia, just to kind of try to understand medication management, and really medication management specific to behavioral symptoms. And so we, and this was a RCMAR funded project, go RCMAR. Within this project, one of the things that we found was, again, kind of underscoring that complexity of medication management, right? Like, you know, how caregivers had to navigate speaking with multiple different healthcare providers, how they had to navigate then communicating that information amongst family members, many of whom were actually living in other countries. And so there was information transfer amongst family members who were all trying to figure out, how do we take care of this person? Some of the issues that we found around language barriers were certainly, you know, an issue where the primary caregiver spoke Spanish, and perhaps there were other caregivers in the family who spoke English, but they weren't the one who was picking up the family member from the hospital or accompanying the person with dementia to the doctor's appointments. And so again, there was kind of this game of telephone of trying to communicate this information that was really complex for the families. And so we just found a variety of different ways in which, you know, some information around medication could really get challenging. There we go. And I think, you know, this is kind of quite clear in many of the things that we've mentioned, but you know, the burden of polypharmacy, of course, it falls physiologically on the patient, on the person who is dealing with a chronic health issue, but of course, there's a tremendous amount of stress for the caregiver administering all these things, right? The complexity of managing multiple medications, the emotional, the physical, the financial stress, the risks, the potential for medication errors and adverse drug events, which of course can really lead to burnout in caregivers. Quite a challenge. So what are ways in which we can engage caregivers in deprescribing? And I've used the word deprescribing a couple of times. And what we mean by deprescribing is really kind of the thoughtful process of stopping or taking or reducing the dose of a medication that's done really in consultation with both the patient, their healthcare providers, right, and their family members. This is not kind of like a situation where someone still stops something cold turkey or their physician refuses to prescribe it to them. That's not really what we mean by deprescribing. Deprescribing is, in an ideal world, meant to be a safe reduction of medications that are no longer necessary or beneficial. And some of the benefits in involving caregivers in some of this decision-making is caregivers have really amazing insights into kind of the daily routines, right? When does this person tend to be the most energetic? When do they tend to experience more dizziness, or, you know, when are they kind of more tired? They can provide, I think, in consultation with the person with chronic conditions, really, they can advocate for that person, right? And provide their thoughts in terms of, you know, what are ways in which, you know, this person could become more active. That was something that we saw, for example, in our study of interviewing Latino caregivers of Latino older adults is, you know, there was a real, oh, good. There was a real, thank you so much. Oh, we're back to, all good, we'll get there. There we go. There was a real emphasis. A lot of our caregivers were really concerned about making sure that our older adults were getting enough physical exercise, right? And so that's something that can absolutely be advocated for. But if the person is feeling too sedated or dizzy, certainly not something that's going to happen. And let's go with just a couple more. Perfect. We're here. Some barriers to deprescribing are that caregivers, first of all, there's definitely, you know, oftentimes when medications are prescribed, there may not necessarily be conversations about the fact that some of them may not necessarily be needed for life. You know, there may be cases in which medications are actually, they're being prescribed for preventative reasons, but that maybe is not the goal at that particular point in time, right? Like the person maybe is reaching their end of their life, or there are other reasons, and you know, in which we might prioritize that person's kind of quality of life. And so even just helping to understand caregivers to understand why a medication may be stopped. In the study that we did, where we interviewed healthcare providers about medication management in the hospital, one of the reasons that they were really concerned about talking to caregivers, to families around why about stopping medications is they were really afraid of making that family member angry or upset, because they didn't want to say, you're doing the wrong thing, right? And so helping healthcare providers communicate that in a way that's really sensitively done, right? Like, so for example, let's say a family member was taking medication to help them sleep, or the person with chronic conditions was taking something to help them sleep. You know, if a healthcare provider is like, oh, why is this person taking this? It could help them, it could lead them to fall. It feels very like blame oriented, right? And so instead trying to provide ways in which, you know, we can kind of make that person still feel very much that they're doing a great job. It's just that they may not necessarily have known the risks of that particular issue. And there's also, for a good reason, there's many concerns about withdrawal effects or of like a particular symptom returning. So something like insomnia or anxiety, right? There's really, it's true that some of these medications are prescribed for those reasons. And so concerns that they may not be addressed if the person stops taking them. So what are some current ways in which we're trying to engage older adults and their caregivers indeed prescribing. There's been some fantastic work by Dr. Ayla Booney, who has been trying to help patients and their families stop medications that are used for dementia, but they may not be helpful anymore. So maybe they were started, these are known as cholinesterase inhibitors. Somebody may be started on these medications, but may not see much of an effect. And oftentimes that conversation of, well, if your family members experiencing more side effects than benefits, maybe it's time to stop that medication. And so what she's done is develop this really nice kind of handout where they're outlining, like, why is this choice? And again, it's a choice, right? Why is the choice being offered to stop the medication? What are the different options that can be done? What else should I know? And then, like, helping kind of the patient and their family rate the benefits and harms of the medication. Like, for example, these medications can cause a lot of gastrointestinal effects. So trying to help them, again, kind of that cognitively complex issue of like determining the harms of medication management, and then really put together a plan for discontinuation of the medications. You know, what is the plan? How are we going to slowly stop these medications over their time? How do we help the caregiver monitor the symptoms? What should they be looking for in order to feel like everybody is actually actively engaged in this choice? So I think that's a really fantastic intervention. Kind of speaking to that issue of language and how do we create really sensitive language to help people and their families stop taking medications. There's been some great research out of Johns Hopkins with Ariel Green, who has really found that a focus on quality of life and reduction of side effects is the #1 most resonant kind of message to families, to patients and their families. So preferred phrases are really around, for example, given your age and other health problems, I'm worried that you're an increased risk of side effects from this medicine. You know, another one might be this medicine has been linked to side effects such as problems with memory, concentration, balance and falls, hospitalizations, and death in older adults. Actually, this reminds me of Dr. Mangione's point about how do we help convince patients, right, about particular vaccinations. It's again this how do we kind of transmit this information well. What they found, so they did a survey where they tested a bunch of phrases with older adults and their families, and they assessed like which phrases resonated most with people. And what they found was the phrase, and this is a little hard to see, but the phrase that resonated the most with people was increased risk of adverse effects. So in other words, really focusing on this is causing you more gastrointestinal issues than an actual benefit was more, way more powerful than telling someone a phrase like, well, you don't need this drug anymore, or this drug will not help you anymore, or the benefits do not outweigh the harms. It really was about the increased risk of adverse effects. And they did this survey on 2 types of medications. One was a statin, so like a preventive medication, and the other one is a sedative, so a medication to help with sleep or anxiety. And it was the same thing. In fact, it was even like more pronounced how much that phrase resonated with families and patients was the increased risk of adverse effects. All of the other phrases like, oh, it's guideline, it's evidence-based, or you can treat this without medicine, or it's more harm than good. Like, no, people do not want to hear those things. They just want to know, is this going to harm me or not? And those were the phrases that really resonated with patients and their families. There's also been some great work in terms of just simple kind of pamphlets that have been developed, given to patients and their families around the risks of medications. We did a study not focused on caregivers, but it was focused on patients who were taking benzodiazepines, so medications for sleep or anxiety. We sent just in the mail, we identified who's taking these medications for long periods of time. These medications can really increase the risk of falls and fractures in older adults. And so we sent them these pamphlets, and the pamphlets, we'll give you an example of their very first thing that they say is, it's the orange ones over here, you may be at risk. You are taking one of these medications. And then you open the pamphlet and it says, here are and it has this little quiz and it asks you, like, what do you think are the risks of these medications? It includes like a story of somebody who stopped taking the medications and is feeling a lot better. They're feeling a lot more energy. And it also kind of includes some resources, like if you want to stop taking these are other things you can do instead. And what we found was that for every 10 brochures that we sent out, one person completely stopped taking these medications with their doctor, I should say. Nobody was quitting these cold turkey, not a good idea to quit these cold turkey, but it's a relatively cheap intervention. And what was really fascinating to us is we actually tracked these patients over time, and we looked to see whether they were messaging their doctors, and many of them did. They sent a message through the patient portal and they said, I had no idea that these medications have these risks, and they were the ones who were initiating that conversation with their doctors, which was really exciting to see. So this is a good example of, and these are available for free. If anybody ever wants to take a look at them, show them to a family member. If you go to deprescribing.org, all of these different, there's some for a variety of different kinds of medications, but a simple intervention relatively have been found to be pretty good about initiating discussions around increased harms. The last thing I want to talk about is really important is also how do we have these discussions with patients who in many cases already have a variety of disadvantages in the healthcare system, right? So, it's this issue of potentially stopping a medication amongst somebody who's already had a really hard time making it to that doctor's appointment, right? We talked about issues about transportation and cost, right? So there was a wonderful survey done by the ABIM Foundation under their Choosing Wisely work. And they asked people, like, let's say you're doing something, you're taking a medication or you have a particular healthcare test or something that's not great for you. How would you want your doctor to talk to you about this? And the most important thing that they said was they really wanted to be heard by physicians. That they valued the quality of their relationship as much as the quality of care, right? It's all about, is it coming from a trusted source? And that they judged that relationship by whether they felt listened or listened to and respected. And really importantly, what they wanted was a comprehensive plan in place. So if you're going to, if the physician was going to potentially say, hey, I don't think you should be taking this medication anymore, they wanted a real plan of like, okay, well, what else? What's next? We're not just going to stop this, but what are we going to do in order to make sure that I don't feel this particular symptom, or what's the plan, right? With clear alternatives. They wanted to make sure that they wanted to feel that their request wasn't just being denied, but that the clinician was trying to guide them towards like safer options, right? And also to make it feel like to make it as a choice, right? A choice that's being kind of made by both the patient and their families. So really, I think really important work. So I mentioned this already, kind of the importance of the issue of really emphasizing quality of life. Other work that's been done in terms of when engaging caregivers, really thinking about adverse effects, which we talked about. And I think lastly too is really thinking about the kind of, particularly with some of these medications that are for prevention, right? Like the adverse effect is being felt right now, whereas the benefits are in over such a long time horizon that person may not necessarily, as I mentioned, like thinking about kind of how long that person is going to live or when they might benefit from that medication, that medication might not make as much sense anymore. So I think a couple of research questions that I've been thinking about, we'll definitely be touching upon more research questions that we'd love to hear from both our caregiver advocates and caregivers are how do we best engage caregivers in different settings, right? So there's such a difference in terms of when someone's caring for somebody when their loved one is in a nursing home versus when they're home. I'm from different communities. What types of interventions work best for different types of caregivers? For example, a family member versus a professional caregiver, in terms of, for example, symptom management, right? And how do we kind of make sure that we train kind of our caregivers in ways that I think are the most kind of culturally and linguistically appropriate. And then what are some ways in which what are some outcomes of caregiver-focused interventions on medication management? So some research questions I've been thinking about, but would love to hear from folks as well. With that, I am going to end here and pass it over to Francesca. My email is here if you want to come and chat with me or come and chat with me over lunch. Thank you so much.
Hi, everyone. Thank you so much for having me here today. Carol, thank you for that wonderful introduction, by the way. I thought I was gonna have to introduce myself, but my name is Francesca Falzerano. I am a second-year assistant professor at the USC Leonard Davis School of Gerontology. So me and Michelle I called you my work wife.
We're
She's also helping me navigate California since I'm brand new and came right from New York, in case you can't tell from my accent. But today I'm going to talk about my psychological approach to the study of family caregiving. So like I said, I thought I was going to have to introduce myself, but I want to start off by giving some context of where I've come from, where I've been, and how I've gotten to this point. So this is just highlighting, I'm an applied developmental psychologist. Usually when I tell people that, they look at me weird for a second because they're like, wait, shouldn't you be doing research on kids? But psychology is really a novel way to look at how the family caregiving trajectory really changes and unfolds over time. So these are just kind of friends I've made along the way, and as I've gotten more and more training and kind of integrating this training in psychology with training in medicine and geriatrics and palliative care. So that's really given me a kind of holistic understanding of the dementia process, the scientific study of the dementia family caregiving process. But I should say, and I would be remiss not to acknowledge that, and tomorrow marks 2 years since I lost my mother from dementia. So dementia has been in my life much, much longer than all of these experiences put together. When I was 14 years old, my mom was diagnosed with dementia. And so I didn't know anybody that was like me at the time. That was something that was very, just not spoken about. And the research phase at the time was focused on the sandwich generation, the very important group of family caregivers, typically women who are caring for their aging parents as well as their children. But what I've really done is try to take a lived experiences approach to informing the family caregiving experience and how we are looking at the experience and the outcomes associated with family caregiving, particularly from a psychosocial perspective. So I'm sure I'm preaching to the choir here with the stats that people always typically start off with. So we have almost 7 million people living with dementia, and 83% of that care is provided by the family caregivers. I'm willing to wager that it's probably a lot higher than that, because I don't know about any of you, but when I was caring for both my mother and father, I was not a caregiver. I was a daughter. And it's interesting to have this kind of distinction between my own personal and professional life. And so that I think that speaks to maybe the amount of people that we're actually missing when we are discussing the development of behavioral interventions to better prepare caregivers to fulfill the tasks associated with the role. And so I like to show this graphic. If you're not familiar, it's described in a concept called rectangularization. So we had the baby boomers when they were born. The population distribution was like a pyramid. As they grew older, people were having fewer kids, and I will get to that in a little bit, but you have that whole bottom portion now of the population that is left to care for the aging baby boomer population. So really what my research has focused on is who are those individuals? And I will get into more context in a second. So we have some really great empirical data on all the bad things that happens as a result of the stress associated with family caregiving. So this is and the Alzheimer's Disease Facts and Figures report always has fantastic information on the latest stats, and 59% of ADRD caregivers are rating their stress either as high or very high, and that is the emotional stress, and that's compared to 38% of physical stress. So what is that saying? And emotional stress is a very, very big construct when we're talking about the complexity associated with how caregiving responsibilities change over time, but also the emotional side, the interpersonal loss that a caregiver has to navigate. So really and there's all of this established research that care-related stress is associated with depression. So about ADRD caregivers exhibit about 30 to 40% higher levels of depression compared to other forms of caregivers. Anxiety, isolation as care intensifies, grief, which I will talk more about in a second, but this has downstream effects on families. I think ADRD should be conceptualized as a family-centered disease. It doesn't just impact the person with dementia. It really changes the whole structure of a family dynamic. And how does that have these kind of more downstream impacts on communities and the healthcare system? So from a 30,000-foot perspective, my broad focus is looking at who are the family caregivers now at the bottom of that distribution. They're not just middle-aged white women anymore because our population is significantly transforming. And then what and why are caregivers experiencing such high levels of emotional stress, and what are the sources of the stress? So when you think about ADRD caregiving, you have the economic implications, you have the stress associated with care, you also have the slow loss of somebody that, a once existing relationship. So my research is really aimed to get a granular understanding of these two kind of buckets. So when I say I'm a developmental psychologist and I use a developmental approach to the study of caregiving, it's because I look at caregiving as a trajectory that kind of changes in tandem with the progression of the illness. So you can see from diagnosis onward, you start to have more progressive declines in cognitive and functional ability, reasoning, memory, etc. And that's how we also see kind of an unfolding responsibility of the family caregiving role. So as the impairment starts to worsen, caregivers might take on more household tasks, assistance with ADLs and IADLs. Then they're providing personal care. They're navigating insurance matters. They're interfacing with healthcare providers. They essentially, what we would need as a football team of staff to essentially do all the things that we're asking family caregivers to do. So it's very important to look at kind of caregiving not in a vacuum, but seeing how it changes and progresses over time. So that means dementia caregivers' needs are also going to change and evolve over time. And it's going to highly depend not only on how the caregiver, the direct care that the caregiver is providing. It's actually much more complicated than that. So I'm not sure if anybody's familiar with this. This is Purlin's stress process model. And it basically is a way to highlight how multidimensional care-related stress is and how it's impacted by the outcomes associated with a family caregiving experience is not just impacted by direct care provision, but it's also impacted by your background characteristics and how caregiving kind of spills over to impact other aspects of your life. So, for example, background characteristics like race, ethnicity, health literacy, where you live, socioeconomic status, how does that influence, the direct care environment in terms of the severity of cognitive impairment, the assistance with ADLs, et cetera. Then that kind of spills over into impacting social life, impacting your ability to balance work or obligations to other family members. And those kind of all mix and match, and they're dynamically interacting across the caregiving trajectory to influence the outcomes associated with caregiving, like depression, anxiety, burden, those things that we're always constantly seeing. And then there are protective and exacerbating factors. So does an individual have the necessary internal and external resources that they feel that they are well equipped to deal with the caregiving situation, the role as it is? And that's kind of going to make or break people's caregiving experience. not only do you have this dynamic interaction between, the individuals, various aspects of the various domains of life, from a Bronfenbrenner kind of ecological systems perspective, we also have to consider the context in which care is embedded. Whether that is not only the direct care environment, your psychosocial environment, also the healthcare system in which we're embedded in, access to services and support. So it's all kind of, this building effect on all the various characteristics that we have to take into consideration. But this is why it's been so difficult to develop effective behavioral interventions. That's not to say that there aren't promising interventions that are demonstrating efficacy in scientific environments. The problem is they're not widespread in the community. And we have over 11 million people that are currently right now in the caregiving role, like navigating it essentially with very little preparedness and support. Usually caregivers don't really have any time for preparing. They are forced to get training on the fly as things progress and change. So the overall premise is that we have to kind of take into account all of these various factors beyond just the direct care environment when we are looking to tailor approaches, especially behavioral approaches, to alleviating caregiver stress. And so, as I said before, the caregivers are no longer just the sandwich generation. The booming older adult population has coincided with a huge change in the population distribution. People have smaller families, they're having children later in life. You have declining birth rates, increased mobility and population migration. I mean, so many of us no longer live in the same cities as our aging parent. And so that has implications on what the caregiving landscape looks like. A lot of my work has to do with kind of looking at these various subpopulations of caregivers. One big one is distance. There are almost 2 million Alzheimer's disease long distance caregivers. And though if you think about what a long distance caregiver is, and they're managing and coordinating care from a significant distance away, their needs, their stresses, their challenges are going to be much different from somebody who lives with their care recipient. So I think it underscores the importance of more personalized approaches to stress reduction. Culture is another big thing. I am an Italian daughter, first generation. Like, culture was embedded in how my family approached caregiving, and how we are looking from as researchers, how we're studying caregiving. For example, in Spanish, there's no adequate translation for the word caregiver. So if we're not even using the right words, that's telling us that, we need to be talking to more of these people to understand what are the things that are going to most resonate in our efforts to kind of advance support. Age is another one that is currently my passion project. There are about 1.4 to 1.5. Well, no, I'm lying. In 2005, there was a prevalence study that estimated about 1.5 to 1.6 million youth caregivers in the United States. Now, these are children under 18 that are not, they're not eligible for typical community supports and services. If you think about immigrant families, particularly, they might be, very young, and think about teenagers or children and where they are in their development. They might be at the forefront of the healthcare interactions, translating very complex information for a family member, taking on these very emotionally heavy concepts without adequate support. I've had people ask me, how do you talk to kids about dementia? And I don't really think that we have an adequate understanding of what that's like and how that impacts not only development, identity, but also their outcomes from there. And then communication, which is really like family caregivers are a key pillar of the healthcare system, and and as Dr. Keller talked about before, their interpersonal dynamics is probably more important than the quality of care provided. So caregivers want to feel heard, they want to feel seen, et cetera. So these are kind of like the 4 buckets of characteristics that I look at in my research program. And so basically, I just spent the last 20 minutes blabbing to you guys about how difficult and complex and messy caregiving is. And it is. And we can't fix necessarily a healthcare system where family caregivers we're so reliant on them, but they're not getting the supports that they need. and I also wanted to quickly mention before I get into my current work is, in addition to the developmental theory that I've incorporated into my research program, I've also done a lot of incorporation of research from end-of-life care and bereavement frameworks. And if you think about now, aside from direct care provision, the actual emotional toll of the relational deprivation that an individual, a caregiver, has to kind of deal with in tandem with managing and coordinating care. It creates kind of these psychosocial voids where the caregiver is deprived of a once really important source of social, emotional, pragmatic support. So when we talk about the emotional stress, that 59% that I brought up at the beginning, all of this stuff has to be considered. And of course, it makes it messy, but the more we kind of seek to understand these characteristics, the more precision we can have in the development of behavioral interventions. So my whole research kind of takes everything I just talked about, and it's kind of exploratory, and we use it and try it and to develop behavioral interventions to alleviate stress. So how can we apply developmental science to explore resilience, adaptation, promote coping, et cetera? And then I don't know if I made SciTech up, but I take credit if I did. But essentially, because again, we have a lot of service and supports that are available for dementia family caregivers. There is a huge gap though in knowledge availability, just knowing that they're there. And so how can technology be used as a vehicle to enhance the delivery of interventions that can target stress? So I've kind of developed my research program is essentially a love child of developmental psychology and technology, with specific emphasis on user-centered design principles. And that's essentially just making sure that we are developing interventions that caregivers are going to use. We're getting it straight from the horse's mouth, hearing about what their biggest issues are, and ways to address it. So really what it is it's an iterative design process. So we want everything to be useful, usable, and accessible. We should be able to give an app or a website, a piece of technology to a novice, and it should be usable by whoever we're giving it to. It means simple. It's not requiring a lot of effort or output on the point of the user. Think about like every time you have to download a new app, how annoying and frustrating it is to try and figure out what you're doing. It's a killer. So the idea is, rather than what we see, typically in the App Store, an idea was generated, they build it, they roll it out, and hopefully they will come. I take an opposite bottom-up approach where we are kind of co-developing in tandem with family caregivers and other subject matter experts to tell us not only the content that they want included in these different aspects of technology, but they should like what it looks like. They should want to use it. And by kind of using caregivers as a sounding board throughout the development process, that can help with the development of more effective behavioral interventions. So I just wanted to quickly highlight this study that I did during my time at Cornell. It was focused on individuals with mild cognitive impairment, but I'm presenting this to give you context about how important usability is and design approaches when we're talking about technology for older adults. So during COVID, we did this study called PRISM, and it wasn't anything overly sophisticated, but we wanted to see if we provided technology and training on the technology to individuals with mild cognitive impairment, would we see an increase in adoption? So now this is during COVID, people are very socially isolated, and we did remote trainings with 50 individuals with mild cognitive impairment, and we just did a simple pre-post test. But we made sure that we taught them how to use all the features, and it wasn't anything fancy. It was email, it was Zoom, it was giving them just basic access and training. What I did. And surprisingly, what we found is over 5 months that depression declined in these individuals, loneliness declined, aspects of social isolation declined, feelings of emotional support increased, and then they also increased in almost all aspects of mobile device proficiency. So it's telling us, and even though it's not directly related to caregivers, it's telling us that it is possible to make usable technologies that are usable by the whole spectrum. The older adult population is extremely heterogeneous, varying abilities. And so this is telling us that technology could actually be used to augment opportunities for not only persons with mild cognitive impairment to get support, but also caregivers. And that kind of leads to my current projects, which is probably why Dr. Keller sees me frazzled every day on campus. So my first two projects are funded by the National Institute on Aging. CarePair is the culmination of my NIA K99 R00 Pathway to Independence Award. And the idea was that Amazon tells me what I like to buy, Netflix tells me what I like to watch. I mean, all the things. Why do I not have something to help me with caregiving? And with all of my experience and expertise in the world, when I was going through it, it felt like I had no tools to turn to. Now, if you also take an extremely stressed caregiver and then ask them to find a support group on Google, it's very quickly kind of a non-starter because it's too stressful, it's too much. So how can we use something like user-centered design and these innovations in AI to better target caregivers' services based on their areas of need? We also want the recommendations we're making to caregivers to be relevant and accounting for their different barriers. I will hurry up because I know that y'all want to eat lunch. I will get back into CarePair in a second, but the living memory home is something that we're about to launch at RCT examining. But the idea is looking at caregiver care recipient care pairs as a dyad, and the idea that mental health is interdependent. So the caregiver's quality of life has an impact on the care recipient's quality of life and vice versa. Another issue is that as the demands associated with caregiving become more intense, it becomes really difficult for caregivers to kind of see the person behind the disease. And so this is an R21 funded by the National Institute on Aging, where we kind of developed it's an online reminiscence therapy kind of website where caregivers and care recipients kind of engage in recalling meaningful memories and activities together. And the idea is to make this kind of living legacy, this living document of the person's meaningful memories, but also to promote personhood of the person with dementia. And the idea is hopefully that it would also alleviate feelings of grief and improve relational quality among care pair dyads. I keep doing that. I'm sorry. I'm also not used to sitting during a presentation. I'm spoiled. So going back to CarePair, this is essentially, it's a web-based assessment and referral platform. So caregivers sign on, they get onboarded, they make themselves a profile, they tell us what their preferences and their barriers to service use are. If they can't leave their house because to attend a support group, then we shouldn't be referring them in-person support groups. So we're trying to kind of streamline access to support. And we're trying to create a very short 10-item assessment to try and diagnose which areas of stress that the caregiver needs most support in. And this one, we're also about to start to test in an RCT, but essentially it came about from asking caregivers and subject matter experts, what are the biggest issues you have in accessing the community supports, resources, and we really let them kind of guide the development. We then developed a prototype of the tool. We told caregivers to break it, tell us what they hate about it, tell us what they find ugly, all the things. We don't just want to know about content, we want to know about interaction, because it needs to be easy and they need to be willing to use it in order for adoption to kind of come to fruition. So we just got that feedback and we did 20 interviews to kind of just tell them, hey, test this out, let us know what you think. And we're using that to then refine the application again before we launch a randomized controlled trial. And the idea is not that like we want to be the next Amazon, but does something like this, kind of a referral navigator that can kind of take away the need for human beings to have to provide the referrals, will that increase use of community services? And it's really just kind of integrating my training on psychological theory with innovations in technology and personalization. That's really what the whole idea behind this is. And we're doing additional usability testing. So in addition to quantitative and qualitative data, we want to know things like how clear is the label? These are things that we might not, outwardly think about that might be very implicit, but like, if somebody doesn't know what the button means on an app, then that's indicative that like we need to change it. So there are ways that we can assess how the technology is doing what it's supposed to be doing, in addition to what the psychosocial impacts are over time. And then this is the last thing I'll say, and I will shut up, I swear. But when I got to USC, my colleagues and I were awarded one of 5 grants funded by the Administration for Community Living, part of this National Caregiver Support Collaborative. And we're funded to advance priority 4, which is advancing workplace and financial security for family caregivers. And so this user-centered design perspective is also being applied in dissemination materials in how we communicate information to various audiences and disseminate resources for caregivers. So that is a very long-winded way of kind of giving you a lay of the land of my research and all the crazy things that I do and why I'm always so frazzled. But going forward, we want to continue to refine and develop and evaluate these interventions, and hopefully embed them into community settings where we can really improve quality of life for both caregivers and care recipients. Thank you all so much for having me. It's been great, and
Great. Oh, I don't even know what to say. Questions, anybody, or comments?
Yes.
Go ahead.
I'm reminded why it's so nice to be among researchers to learn new words like deprescribing and depersonalization.
Use it in a sentence.
I don't know, that might be a common word. I think, and there's a concept of that, which is just like weaning, right? And I'm curious, and I don't know if this is just in the Asian American community, but doctors don't bring up deprescribing. And the caregivers don't bring it up because they're expecting it to come from the doctor, right? The authority figure. But we find that they're kind of de facto deprescribing themselves because they may not fully trust medications but they're not doing it with any, like assistance, like what's a proper dosage to use? Or we'll hear things like, oh yeah, I had him taking the diabetes meds these last 3 days because we're gonna go to the doctor, right? So it's like yo-yoing. So, I don't know if you encounter that or if it's specific to specific communities or,
No, I think I think that what you're describing is very common. I think, oftentimes there is a lot of trial and error happening in families, right? In terms of thinking about like, well, is this medication actually really helping them? Maybe we should just stop it. And then, but you're right. I think part of the challenge is that there's, there's not a lot of training for your kind of typical primary care physician. Our geriatricians, for example, very knowledgeable about deprescribing, but somebody who's trained in primary care may not necessarily bring up, these issues of deprescribing. They may not have the resources to, for example, know like how should a medication be slowly tapered over time. That's some of the things we've encountered with some of our work is we have to train before we actually talk to the patients, we have to train the physicians in terms of like what is safe and tolerable for somebody. And I think that's a really fantastic point of how can a healthcare provider bring up issues like, hey, is this medication still working for you in a way that doesn't feel like if you stop taking it, it's not like, oh no, like you shouldn't, right? Because medication burden is a real thing and people don't necessarily, or not, but they're not always adherent to the medication. So understanding the why and figuring out, I think these are really amazing areas for research to try to understand that better. Really good points.
You mentioned, with respect to describing, you mentioned the issue about placing blame or making the caregiver feel like they're doing something appropriate. But also the flip side, have you considered how, prescriptions may come from various sources, not making them feel like their physician or their provider is doing something against their best interest or increasing that kind of mistrust towards the provider? Have you considered looking at the right phrasing and framing for that as well?
I think that's a fantastic research question to look into that. Really, I think like thinking about the framing around that, definitely, I'll brainstorm with you. Thank you.
That sounds great.
Yes.
Okay.
Question for both, for statements, but one thing to consider that I know was a big hurdle for me, is that with medications, we know that sometimes, and providers will tell you, you may not see results or effects for the following 2 weeks, a month, or whatever, and it's like, as a caregiver, you're trying to notice these things. Is it worth it? Is it not? I know that in most patients, and particularly certain communities, it's like, if they don't see effect right away, I'm not taking this. Why am I taking it, right? And so you end up playing that role of a monitor and witness, and being able to take that window of looking at your family member or the person you're giving care to, in terms of, okay, what am I witnessing? Is it working? Is it not? Then can we have the conversation about removing this, deprescribing, or what have you? I think that's an intervening variable that caregivers sometimes may not be aware that they have that role to observe. And my comment in terms of the tech, if you will, vision of this, is the consideration of the intergenerational differences, right? So the person at the high end of the peak in terms of older may not be comfortable with some of these things. And so then the caregiver, who may be a different generation, maybe look at it different, or in some communities, it ends up being further placed down to the younger, who are much more tech savvy and can manipulate these things for you, but it's not the actual person dealing with it. So then there we go again. I have a very sensitive spot for children who handle adult issues, having been one, okay? So you have to consider those generational differences in terms of development. I agree, easy, graphic, and whatever to manipulate, right? But some people, that's not their comfort zone. So they're gonna reach out to somebody else to do that. And so.
And that training piece is something that always has to be
Absolutely.
at the forefront, because we think also it's the training and the assistance that they're getting from other people that really is contributing to adoption. And also, I'll just really quickly say that, like, so as part of my research, what we want to do is look for those intergenerational effects. So, and look at the case of, like, if an individual has visual impairment, let's say, how are they seeing it? Like, kind of replicating and doing simulations on how the application looks, how somebody with cognitive impairment might have difficulty with navigating it. So we really are just kind of scratching the surface on how to make it accessible for everybody. But you're absolutely right, and that's something that has to stay at the forefront.
So you touched on an issue that I looked for so much in the literature, and I experienced so much with my parents' decline over 9 years. And that is really the issue of finding the person and kind of tapping into that, especially when there've been profound losses. Like, they don't recognize you anymore, right? Absolutely. How do you teach that?
TBD. No, but I think just awareness is a big thing. And I think from what our caregivers is saying, they're expecting things to come from the doctor, a diagnosis, and what to expect. And ADRD is really characterized by multi-dimensional losses. And they're serial losses that occur over time. So it's very easy to kind of forget the characteristics, the personhood of the person with dementia. I think a lot of it is because they're not given the preparedness they need on what to expect. So the jury's out, but hopefully by promoting activities that individuals can do together, it will foster kind of
Yeah.
just,
Are you building that content?
yeah.
You are,
Yes, we
very
are.
cool.
Yeah,
Very
thank
cool.
you.
I think some of the most helpful things I learned that I shared with friends and patients is, when your parent stops recognizing you, when you go to visit, open the door, say, hello, mom. Carol's here, your favorite daughter, to make you breakfast. And it's like, there's a big smile rather than hearing, who's that lady who just walked in, and it's like small kind of verbal cueing like that can like totally change the interaction.
And so just as,
And,
all focus on
I've
gain.
had patients come back to me where caregivers will go, oh my God, that's like totally changed our relationship just by doing that.
The
you know?
simplest thing,
And,
exactly.
it's kind of like, rather than crashing into the deficit, finding where the deficit isn't and spend time doing that.
Exactly.
And it's just something that like I've seen nowhere in the literature. So I think what you're doing is like really profound, really profound. So thank you. And with that, maybe we'll have lunch.
Yeah, so lunch buffet is right here. We can come back and sit in here, or there's also tables outside that we'll share with the other big room next door. So please enjoy. Thank you.
So do we know what the other group is so we can see if we really want to sit down?
It's the women's center. Women's
You never know.
I was thinking exactly.
Like. Yeah.